very good morning to all. First of all, let me thank the organizers, especially Dr. Jyotidev Keshadev sir and his team for giving me an opportunity to chair the session. As we all know, a significant proportion of diabetic patients are not achieving target glycemic control even after regular treatment and follow-up due to multiple reasons. Physician's inertia or clinical inertia is one of the important reasons for this. To talk on the consequences of physician's inertia or clinical inertia and how to tackle the issue, we have an eminent speaker, Dr.Manoj S Chawla, who is a consultant diabetologist at Lina Diabetic Care and Mumbai Diabetic Research Center, Asian Heart Institute and Research Center, as diabetologist and coordinator of Department of Endocrinology and Diabetology. He is the president of United Diabetic Forum and principal investigators in various global MNC clinical trials. And he is the invited speaker and chairperson at various national and international conferences. And he is a recognized authority in the field of insulin pump and CGMs. Over to you, sir.
Thank you, Chairman, sir. A very good morning to all of you, and a big thank you to Dr. Jyotidev and the JPF Convention and Foundation for inviting me here today to speak on this topic of inertia. So I think there are various types of clinical inertia, and essentially it's the inertia from clinicians which is most bothersome, not even the patient-related inertia. So over the next 20 minutes or so, I'm going to be speaking on this topic about the need to initiate insulin much earlier on, and how should we be going about in terms of optimizing the therapy and intensifying the therapy. So clinical inertia largely can be looked upon as the patient and the physician-based barriers. And if we see amongst these barriers, you will see patient perceptions of insulin treatment and outcome, a lot of perceptions which they have, the fear of hypoglycemia, the impaired quality of life that they feel that might bring about, the lack of patient adherence to treatment, most treatments, more so any injectable therapy, the financial restrictions that the patients might have in a self-pay market like ours, the beliefs about patient competence, whether they can take, these are again barriers from the physician side, the resource issues towards injectable therapy, the risk of starting these therapy in patients with various comorbidities and disabilities, sometimes the entire complexity of the regimen that a doctor might prescribe when starting injectable therapy itself becomes a big barrier, and the fear of weight gain and the lack of education towards the disease and the treatment possibilities. So what is clinical inertia? If I had to define that in simple words, it's the tendency to maintain the current treatment strategies despite the results demanding escalation, substantially contributing to disconnect between the clinical aspiration for patients with diabetes and targets achieved. So often that we want to be in our comfort zone, the patient doesn't want to move, the patient is constantly telling us about asking for more time to get to target, do not move to insulin therapies, I went wrong, there was the mango season, there were festivals, and the patient is constantly bargaining with us not to move on to insulin therapy. We also often have various reasons for inertia. Sometimes we want to empathize with the patients, sometimes it's the busy OPD out there, and teaching insulin will probably take longer, and it's already 8 in the evening, you have another 15 patients to wind up, let's keep it for next time, I don't have the resource to do that today. So various reasons for inertia, and we keep pushing the initiation of insulin therapy much later than it should be, and this is clinical inertia. So the patient and physician barriers to insulin initiation. Now if you see here in the light blue graphs there, these are all barriers which are physician related, and the darker blue ones are the barriers from patients. So be it the fear that insulin might make one fat, or the fear of hypoglycemia, the pain from injections or the pain from blood tests, for patients it's similar perception of fear or the barrier, but largely the barrier comes from the physician side. So the fear of hypoglycemia is not what the patient perceives. A small percentage of them who might have had an experience with hypoglycemia might be worried, but it's the physicians who are more worried about hypoglycemia or the perception of pain or starting an injectable therapy. So to move on for better treatment for our patients or to try to get our patients to target, I think it's we physicians who need to really overcome this inertia, as very well documented in this paper. The consequences of inertia is that our patients remain on multiple oral therapy for far too long. And the sad part is that 41% in this SOLVE study had an A1c of more than 9% by the time they were initiated on insulin after being on oral therapy for years, and 22% had an A1c more than 10. And I'm sure all of you will agree that that's not the target that we want for our patients, lingering at 8.5, 9 and 10%. We would all believe that we want our patients to be closer to 7 and in some cases much lower than that. And if with whatever possible therapies we are not reaching the target, we need to get in injectables, insulin especially, much earlier. So overcoming the clinical inertia, and that's been our typical way of treating patients, isn't it? That we would be talking about lifestyle, diet and exercise, oral monotherapy, moving on to oral combinations, and then oral plus insulin, which is where the biggest hurdle comes in, of moving to that first position, and then probably another bigger hurdle when we move to multiple insulin shots a day or the intensification for insulin therapy. So there's a barrier at every step, and there is reluctance for the patient to move on to injectable therapies, and much more to move from one shot to multiple shots a day. No doubt, all recommendations, all the bodies would recommend early use of insulin much earlier than we all are using. So the recent ADASD guidelines would also put insulin therapy right up there. Post lifestyle modification and metformin, if you're not at target, consider insulin therapy right from the beginning. And we all have believed that whenever in the stage of life of a diabetic you are recommending insulin, you're never too wrong. Whether it's right at the beginning or it's in the initial couple of years or much later, you're never too wrong in starting insulin therapy. So whoever does that, we know that you're rightly placed at whatever stage you have recommended insulin. But this is the pattern that which we all are following. And when I say this, I'm pretty clear in saying we. It's not you, it's not I. I think we all have been going wrong in terms of not initiating insulin as early as we should. And this stepwise therapy that we've all been approaching hasn't really yielded results that we want. The complication rate today amongst our patients is much higher. In spite of gaining knowledge about the way diabetes works, that it's progressive, there would be complications, we really haven't done much to get our patients to target, and which is why that dismal rate of our patients maintaining A1c less than 7 would be about 40-45% in good centers. So this is what we've been doing. And hence, that's resulted in poor and fluctuating glycemic control, the ups and downs. We know today that we're talking about the other parameter of glycemic variability as a big contributor to the chance of complications. And I'm sure over the next day or two, there would be a lot of talks on glycemic variability and glycemic excursions. So this is something which we can avoid by initiating insulin much earlier. Important to remember that the first 10 years of diabetes are these golden years. We need to take action much earlier. By continuing to drag our patients on multiple oral therapies, we're just causing the beta cells to fail for sure. Having started insulin earlier, the results are going to be much better in our patients, and maintaining that beta cell function is going to help in preventing the so-called fluctuations that you might see post beta cell failure. So is it time to change our approach? Probably yes. So let's see how to overcome these barriers. And one of the barriers that we talk about in insulin management is maintaining the balance between hypoglycemia and A1c. We want to get the A1c to target, but the biggest state, the limiting step there is hypoglycemia. We need to be clear about how to initiate insulin and how to minimize this chance of hypoglycemia. Importance of initiating early insulin therapy? Yes, all the targets, which are the recommended targets, would say anywhere between less than 7 to less than 6.5. So there isn't much doubt in our minds that we can't let our patients linger at 7.8, 8.2, keep buying out time. That's not going to help. We need to get them to the target, and for that, if they are not responding to the existing various oral therapies, it's time to start insulin. Now, what would be the other barriers and the reasons that would here for missing an insulin dose? And these are graded very well in this paper by Pyroth et al. Whether it's too painful or the regimen is too complicated, one wants to avoid weight gain, to skipping a meal, to having stress or having fought with spouse or children that day, we'll see various reasons for why patients miss insulin. And this is important for all of us who prescribe and recommend injectable therapy to understand the mindset from patients. And trust me, when we start doing it ourselves and we start asking patients for feedback as to why they missed out on insulin, a lot of us will be able to come out with interesting reasons and answers which we can add to this study as to why patients are missing insulin. So the cause and solution to some of these barriers, in terms of insulin therapies, do not look at multiple or complex regimen, look at simple treatment regimes. Fear of weight gain, hence the need to re-emphasize on lifestyle modification post starting insulin so that weight gain is minimal if at all. There needs to be proper communication between the healthcare practitioner and the entire team with the patient and family. And look at using cost-effective medication so that it's well accepted by the patients in terms of injectable therapy. Initiating insulin therapy. So having convinced most of you that we need to get our patients to target and we need to start insulin much earlier, the question arises, what kind of insulin therapy do we use? And what are our options? One might talk about using prandial shots of insulin. There would be thoughts on using just basal insulin. In India, there would be traditionally a lot of thoughts about using pre-mix insulin. And then of course, the probably holy grail of basal bolus. But in terms of starting these therapies, we would see largely it boils down to whether we're going to be starting with basal initiation or pre-mix. And then again in pre-mix, we're talking about 1 or 2 shots a day. So basal hyperglycemia, and let's look at it fairly at both these options, basal as well as premix initiation. So this is telling us that basal hyperglycemia largely contributes to more increased A1c levels than does postprandial. And these are some slides favoring the use of basal insulin as a means of initiating insulin therapy. So one would argue that basal hyperglycemia contributes almost to 2% of A1c, whereas postprandial would be contributing to 1% of the A1c. And hence probably need to fix the fasting first, and a strong base and evidence for initiating basal therapy. When I say basal therapy, it would be any of the basal insulins, be it NPH, glargine, detamir or degludec. Any of these would be a part of the basal therapy. So a concept of fix the fasting first, and that's where probably you're right in starting the therapy with basal insulin. Now when you start initiating with basal, where do we do this? If there is predominant fasting hyperglycemia, you're probably right in using basal insulin. It can be combined with OADs as well, you don't have to knock them off. Whatever OADs you're using, you might bring down the dose, you might continue the same, start with basal insulin at any time of the day, depending on the kind of insulin you're using. Simple titration algorithms. So one of the barriers we mentioned was start simple, start slow, give those algorithms to the patients where they can titrate themselves, and that makes the job much easier. You could initiate probably with 0.1 unit per kilogram or simply around 10 units per day and titrate in terms of +2, -2 every week to get the patients to a reasonable target to begin with. The advantages with basal, probably one injection, so you're not talking about mixing. When you are initiating insulin, you don't want to have complex instructions to be given to the patients about mixing, about making the shots. Most of these would be in pen devices, so 1 shot a day. Slow, safe and simple titration. The chances of hypoglycemia are much lesser. Usually low dose with basal insulin because you're still using the oral drugs. Limited weight gain if at all. Effective improvement in glycemic control. So very often you will see when you initiated basal with patients of A1c 9.5, 10, 10.5, within months you've been able to get it down to 7.5, 8 and shown this effective decrease in the A1c. At single evening dose probably of 10 units, you could be using any of these insulins, increase the dose weekly and adjust the dose by the fasting. So most of these basals, except for MPH, you would be looking at your fasting glucose and adjusting the insulin dosage. Timing is everything in the basal insulin preparation, so important for us to know how do they start their action, for how long they are effective. And largely then the focus again would be on glargine, detamir and degludec as the newer insulins, much flatter duration, much flatter profile of action, and the duration could be anywhere from 20 to 40 hours. Now, looking at the other perspective, a lot of us might believe that it's not only basal, but premix has been the traditional way of initiating insulin in India. Excuse me. And we've been doing that. So what does evidence say for initiating insulin with premix? The argument would be that in a predominantly carb-eating nation, in that culture, postprandial hyperglycemia is probably contributing as much, if not more, than fasting hyperglycemia. And we are eating every few hours, and hence, for a couple of hours after that, the body tends to remain in the postprandial state. So maybe basal insulin might not be the best option, but you might consider using premix insulin. So initiation of insulin treatment, why premix? Okay, my timer went out, so why premix? Because of targeting the postprandial hyperglycemia. So PPG is a major contributor to overall glycemia across a range of A1c values. Also, the DECODE study showed that any fasting level of glucose postprandial, a higher postprandial will always contribute more to the complications, and hence probably targeting postprandial challenge is important. What does the Indian National Consensus Group have to say? So the INCG came out with its recommendations strongly suggesting the use of premix insulins as a possibility in Indian patients. And it also gave means of titrating insulin therapy. If you're using the premix analogs, you can continue to titrate, and if it crosses more than 30 units per day, go from once a day, initiate with once a day and then split it into twice a day. For human premix, you will probably be splitting the dose once you cross 20 units per day. To be fair, the initiation of insulin therapy, let's look at what the world has to say. The ADA and the ACE would strongly recommend initiating insulin therapy with basal insulin. The IDF would recommend initiation of insulin that has a more balanced preview, similar that you use either basal or premix. The INCG would be more in favor of using premix insulin, and the guidelines published in JAPI last year said that when fasting is higher, consider using basal to initiate. When both fasting and PP are higher, consider initiating insulin with premix, probably very quickly moving from one shot a day to twice daily. So to be fair, these are where we stand in terms of recommendations, but important for all of us to take the message home, we need to initiate insulin much earlier. Look at your comfort zone and decide whether you want to use basal first or premix, but initiate earlier. Quickly, Chairman Sir, I'll take a couple of minutes to wind up on the intensification part. So initiating insulin therapy, optimizing would be where we are increasing the dose or optimizing the dose to get the best result from that particular insulin regime, and then realizing that if you are not at target, let's not hesitate, let's not again get into inertia and not intensify to reach to the actual target A1c of less than 7 or 6.5. So this is insulin optimization and intensification. It should follow the disease progress and hence move on quickly the moment you don't get results from one shot of insulin or initiation, up titrate and intensify. When you talk about intensify, again, enough evidence to say that we need to be at target and we should intensify. What are the options when you talk about intensification? And these are what the various societies would say, that whether we continue to use basal plus, that means basal and one shot of short acting, or we increase the premix numbers. So that's been one other convenient way, that you're already on premix insulin, move from premix OD to BID to TID, or a large number would believe that the ideal way or more physiological way of intensification is post basal, start adding a bolus insulin with each meal that is showing the rise in sugar. So moving from basal to one bolus with the meal that is showing the highest postprandial hyperglycemia, and then if required moving to 3 shots of bolus, the typical MDI basal bolus therapy. But what's the problem with intensification with just basal? You're going to only be targeting fasting. Only basal insulin intensification will not help in covering the postprandial. And hence, the options of intensifying with premix therapies, whereas clear evidence show that you can go, whether it was the 1 to 3 study or the convenience of just having initiated with premix, moving up to premix twice a day or thrice a day. The other option being moving to basal bolus. And then again, you have the option from shifting. So very often if you've seen your comfort of starting only with basal insulin, a lot of us would decide that when the patient requires intensification but is not ready to move to the entire basal bolus regime, shifting away from basal and getting into a premix twice a day might be an option, and then moving from premix twice a day to thrice a day where required. Again, multiple injections and dose titration. So if you're moving from premix twice a day, to the basal bolus therapy, the one way of going about it is look at your total daily dose, use about 75% of that and divide that half into basal and half into bolus. This would be a similar principle when you're shifting from any insulin regime even to an insulin pump. Typical principle would be cut by 20-25% and divide into basal and bolus on 50%. So intensification to full basal bolus offers most precise control. Basal with mealtime insulin at each meal offers the precise control. Also requires multiple injections, so that has to be kept in mind. Many patients are reluctant to start with a basal bolus insulin regime. Hence, this requires motivation of both the patient and the doctor and doctor's team. Comprehensive training probably in carbohydrate counting. So obviously with this little complexity involved, it's not something that you initiate therapy, but with years of initial insulinization, you move on towards that where it's required. A brief mention of another option in insulin intensification today is the Insulin Co Formulation, which is IDEG-ASP. We have degludec with aspart 70-30 combination available. So that's another means of starting from basal and intensifying with basal plus or this co-formulation. And this again co-formulation in various trials where it's been compared to the premix therapy has shown good efficacy, non-inferiority in terms of A1c, and probably some advantage in terms of hypoglycemia, having overall less and nocturnal hypoglycemia. So to summarize my talk, thank you for that minute, I'll wind up. To summarize my talk, in terms of insulin intensification, the overall aim of insulin therapy is to achieve glucose levels as close to normal as possible. As glycemic control deteriorates over time, insulin intensification becomes inevitable in most patients. So let's drive out that clinical inertia amongst us. Intensifying with basal bolus, basal plus, premix or IDEG-ASP can help achieve the target. You have the option in front of you, but the idea is intensify to reach the target. So to summarize, considerable inertia surrounds insulin initiation and intensification, and hopefully forums like these created today and the knowledge spreading helps all of us take this decision earlier. Many issues contribute to inertia and consequentially many potential solutions have been discussed today. Patients and in capital physicians is where I would put it down to have a major role in overcoming this inertia. Thank you so much.
Thank you, sir, for your excellent presentation. The topic is open for discussion.